Thank you so much, Dr. Beena. I would also like to thank Dr. Saleh Isaac for joining us.
Next, we have Professor Dr. John Axford speaking, who is a consultant, adult and pediatric rheumatologist and a professor of clinical rheumatology at St. George's in London. Please welcome Professor Dr. Axford, who will be discussing polymyalgia rheumatica and its many guises.
That's that. What button do I press?
Yes.
That one?
Yes.
The middle one?
Yes.
Okay. It's really fantastic to be back here, and very many thanks for inviting me. It's indeed a privilege and pleasure. The last time I was here in 2019, and it's been much too long. So I think one thing I share with everybody in the audience is our love for rheumatology. And if you look at all the titles, there are the many guises, the many faces, untangling rheumatology, and I think we all just love sitting in the clinic in the morning and seeing what's going to walk through the door, because you just never know. And something that's been intriguing me over the years, as some of my lectures have become a bit repetitive, is what is the patient experiencing when they complain of myalgia? Because they may have heart disease, lung disease, all sorts of other non-rheumatic diseases, and then there's the whole group of rheumatic disorders in which myalgia is central to it. One of the disorders that I've become clinically interested in over the years is polymyalgia rheumatica. And you'll see here, this is what the textbook, indeed my textbook, says that you should be expecting as it walks through the door. These are the usual pathogenic culprits. And in general, this is a disease where you have to speak to the patient and understand the patient, and sometimes try and interpret what the patient is experiencing. And this is the picture you build up in your mind as the patient tells you their experience. But it doesn't have to be exactly like this, and this is one of the intrigues of rheumatology. And this is one of the significant successes of rheumatology when you do your steroid trial in these patients, and they come in sometimes with quite significant disability, and 2 days of corticosteroids, it's all gone, and they're friends for life. And don't forget that some of these patients may have synovitis, and this can lead to a little bit of confusion in regard to rheumatoid arthritis, but this is totally compatible with polymyalgia rheumatica. This is what the textbook tells us, and this is sometimes where the diagnosis can become confused and delayed, because you don't always have to satisfy textbook criteria for the diagnosis. And sometimes, of course, you need to do tests of physiology to see whether the inflammation these patients are experiencing can overflow into the body in general. But PMR is undiagnosed because it's not immediately obvious to the treating physician. It's obvious, but you're not expecting it, so you miss it. One of the more common causes for its misdiagnosis is the ESR is not elevated. And one of the worst ones, God bless them, if you get referred to a surgeon, because then you know every single investigation finding in PMR possible, for example, soft tissue inflammation. So I'm going to take you through a number of patients I've seen over the years and tell you about my diagnostic dilemma. So this is Gay. She felt really unwell over a 6-month period and had a general decline in her health, and fatigue and myalgia was central to it. She had 3 bilateral ear infections associated with antibiotic treatment, and she also had a degree of soft tissue inflammation and synovitis. She had a significant inflammatory response, no immunopathology. If you do ultrasound and MR imaging of the soft tissues, you always find bursitis in these patients. So what's the important clinical observation? When you're sitting there looking at me telling you about this, what do you immediately think, oh, that looks a bit odd, and what blood tests will you order? Well, of course, you're all sitting there saying, the important thing is why did this lady have ear infection and recurrent ear inflammation? The blood test you would think about doing in your non-screening blood test, but when the penny suddenly drops, is ANCHOR. And of course, the diagnosis here in this lady with myalgia is that she has ANCHOR proteinase 3 antibody positive acute granulomatosis with polyangiitis. And indeed, this lady's been seeing me probably for about 5 years now and tipped up at my clinic on Monday with a parotid infection, which I didn't think was related, but it could very well be. So you make friends for life with these patients. This is Jubilee, who turned up, you can see, in 2008, and she's still very friendly with me, again with scalp and head tenderness, weight reduction, and whole body myalgia. A small inflammatory response in her blood tests and nothing else going on with her. So when you're sitting there talking to her and you're building up this picture in your mind, what is something that's sticking out here that is salient, and what investigations would you order? But of course, the important thing with her is that head pain, head radiation, scalp tenderness is something that you want to delve into and think about. And what do you think about eventually doing is an ultrasound, perhaps of the temporal artery, or a temporal artery biopsy, if you can find a friendly surgeon that's able to react to your wishes. This is what her temporal artery biopsy looked like. These are non-caseating granuloma here, and the whole of the temporal artery, you see, is totally occluded. Diagnosis here, yep, you're quite right. Acute giant cell arteritis. And this is an intriguing disease. She responded very well. But then they relapsed with arteritis in various other bits of the body. And she played a trick on me and had gastrointestinal arteritis as a manifestation of a relapse once, only typified by feeling unwell and with weight loss. So this is Sarah. And she came, this is becoming a bit recurrent, isn't it? General malaise, arm pain, Raynaud's, feeling unwell, weight loss, etc., etc. This is something that you probably don't know much about in Lahore, bell ringing. It's a common practice, pastime in the UK, because we ring bells in our churches, and it's a highly skilled practice that Sarah taught me all about. And she was pyrexial when we first met. She had mild Raynaud's. She was systemically unwell. So what examination would you do and do you do in all your patients that come into your clinic, and what specific diagnostic investigations would you think about doing? Well, of course, what you want to do is check their arterial pulses and check blood pressure in both their left and their right arms, because this lady was complaining about symptoms of pain and inability to carry on her pastime as a bell ringer, which involves using your arms a lot because you're ringing big, heavy bells. So what you think about doing is arteriography and PET scanning. And this is the arteriography of Sarah, and you can see that she has significant narrowing of the aorta at its isthmus here where the arrow is. So this is an arteriogram. This is the PET scan, which is very clever. So this is the CT bit, this is the PET bit, and this is the combination. And you can see there's significant inflammation of the aorta as indicated by the arrows. So the diagnosis with this lady with myalgia, like all the others, is she has Takayasu arteritis, and she's been well treated with surgery and immunosuppression. So isn't it fantastic, rheumatology, all these things that patients can come to you in your clinic on a Monday morning. So this is a patient where no one really knew what was going on with him, because all he had was his complaints, but all his blood tests were normal. And the family practitioner said to me in the letter, it can't be polymyalgia rheumatica because this guy's too young. And he'd been sent around London seeing various orthopedic surgeons for his shoulders, for his hips, for his back, and having lots and lots of investigations done. And one of the intriguing things here is, and surgeons can never really quite understand this, is they inject the right shoulder and the left shoulder gets better, because you're dealing with a systemic disease. So you take the history, you make the diagnosis irrespective of the age and the gender of the patient, and then you put you trial corticosteroids with these patients and you see what happens. So this is Raoul coming into my clinic here, unable to elevate his arms. And of course, 3 days later, the trial of steroids was positive. He could brush his hair. One of the problems that young patients have, or patients that decide that they're going to do it themselves, is that they rapidly reduce the steroids, the symptoms all come back again, they go and see orthopedic surgeons, and this guy went through 3 cycles of PMR until he reverted back to my clinic, and now he's under very, very tight control. So down here, the take-home message is don't worry about the age. Polymyalgia rheumatica can affect any age, okay? Really be conservative about your steroid reduction. I do 1 milligram per month, which infuriates some patients. But if you rush it, it all bounces back on you, and you end up using more corticosteroids than you would otherwise wish. And don't let orthopedic surgeons near, God bless them. So this is Janet. I'm just going through a number of cases that caught me out somewhat. She had stuttering polymyalgia, came with a bit of knee pain, came with a bit of shoulder pain, and over the 6 months, it all came together as polymyalgia, trial of corticosteroids, and she did very well. And this is probably the initial case of a number of cases that can be built into a presentation and some discussion. But I do a lot of DEXA scans, and she had one done in March, she had one done 2 years later, and they were all entirely normal. She then came to see me 6 months, 4 months or so ago, saying that her pain was increasing, and she feels as though that she's losing stature. We put the corticosteroids up a little bit, and she said, well, it's just about okay. But then the lumbar back pain became a crescendo, and I had to think about other things and do other investigations with her. And of course, what she had was silent osteoporotic fragility fractures all the way up and down her lumbar spine, as you can see here. And this, of course, is in a lady with 2 very, very normal DEXA scans and on very minimal amounts of corticosteroids over a 1-year period. So the question here is, should we go back to what we were doing in the 1990s and put our patients on bone protective drugs every time we initiate corticosteroids? But I have a number of patients who were on denosumab prior to multiple back fractures, so that's probably not the right answer. This is Simon, a man who was 68 when I met him, and he had very typical generalized polymyalgia, responded very nicely to corticosteroids, but he kept on coming back to the clinic and doing Zoom consultations with me, personal consultations with me. He's really getting very frustrated because he couldn't get below 8 milligrams of steroids. You put it up to 10, and he did very well, but he got stuck on 8. And it's very easy just to hear this and to understand it and interpret it as polymyalgia. But if one goes back through my notes and things were becoming a little bit more non-polymyalgic, tinnitus, dizziness, examination again, moderate stiffness. Over 2 years, he had 4 cycles of steroids. And then things that tended to focus away from polymyalgia. And then he got some upper limb paresthesia. He felt his muscles were seizing up. Still partially responsive to corticosteroids. Dizziness and slowness took the place of the myalgia, but of course these patients complain of dizziness and slowness if they have polymyalgia, so a difficult one to dissect out. There we go here. So I sent him off to a neurologist, and I said, what do you think is going on here? Because I was getting concerned about his neurological symptoms and his slowness, etc. And he did a DET scan, MRI, looking at dopaminergic chemicals in the brain, and this is these are the ventricles here, and down here is the putamen on both sides, and you'll see that on the left-hand side there's loss of dopamine transporters in the left putamen. So this guy has polymyalgia, but throughout our relationship he was developing Parkinson's disease, which was confusing me somewhat because of course the Parkinson was causing stiffness. So the take-home messages here are: always refer to a rheumatologist, always expect the unexpected in your clinic, learn to listen to your patient and dissect out and try and help interpret the symptoms the patients are telling you. And if you are concerned about myalgia and inflammatory myalgia, then a trial of corticosteroids is diagnostic and need only be carried out over a matter of 5 to 7 days before you know exactly what is going on. Don't forget, though, that the drugs that you're using do have common adverse effects and mood swings. This is the lady here that said blood pressure, anxiety, and she called it roid rage. Steroids can cause a lot of adverse effects, but keep calm, drink tea. And this is part of my quiz later on, but I just so happened to be seeing the grandchildren in Birmingham and came across this. So what tree is this? And I actually sent it to my colleagues in Lahore, and I got no response. So I felt very proud. And there are not many hands going up. This is the Himalayan cedar, and this is your national tree, did you know? And that's in Birmingham, in the Botanic Gardens, if you want to go and visit it and look at it. So thank you very much. This is my team in London, and again, a great pleasure.
Thank you so much, Dr. John, for this enlightening discussion.